Hi, I'm Sean Panzer, and today I want to talk to you about the some common disorders of the gallbladder and the pancreas. And I'm a gastroenterologist, and with North Texas Gastrointestinal Associates. We're located at 2501 Scripture Street, number 201, Denton, Texas, 76201. Phone number 940-566-4720. Fax number is 940-566-4727. And the website is www.ntgia.com. So the first thing I want to do is just go over the normal anatomy like I do in all of these talks. And so when you swallow, food goes over the tongue, comes down this long tube called the esophagus. Your lungs are on either side, your heart's here, your windpipe's up here. The food goes into the stomach where it mixes with acid. Muscle of the stomach grind up the food. It sits there a while and then goes into this C-shaped area called the duodenum. That area is important because you have two things emptying there. One is your pancreas running right here behind your stomach. It makes the juice that you need to break down food. It also makes insulin, which is important for your blood sugar control. The other thing emptying there is your liver, and it makes a lot of things, one of those being bile. Bile goes into tubes called bile ducts. They come into one main one that goes through the pancreas and out to the intestine. Gallbladder is attached there and serves to store the bile until you eat, and then squeezes the bile in to mix with the food. From there, it goes down about 23 feet of small bowel, during which time nutrients are brought to the body, water and waste is left behind. It comes out in the right lower part of the belly in an area called the cecum. Your appendix is down there. As your water and waste goes up the right colon, across the middle, down the left colon, makes this S-shaped turn to where it comes out, water's removed, still becomes firm. Okay, so we're going to look more specifically at diseases of the in this area here, of course, pancreas and gallbladder and the bile ducts. And so to speak first about the gallbladder is part of the what we call the biliary tree, and this is a system in which you have kind of one main drainage tube that comes down and comes into the right upper part of the abdomen and inserts in this C-shaped area called the duodenum. And so it is like an upside down tree. You have one main trunk here that then branches into a right and left hepatic duct, and then it goes into smaller and smaller branches as you go into the farther out into the edge of the liver. And then you have the gallbladder here. You have this little valve down here at the bottom of the bile duct. It's a structure called the ampulla of Vater, V-A-T-E-R, and it has what's called the sphincter of Oddi, which is a muscular ring that goes that covers the common opening shared by the pancreas drainage system coming in here and your common bile duct. This is called the pancreatic duct, and they come to a common opening here. And so the bile is basically produced from a breakdown of your red cells, and so it comes into the and it's basically a breakdown product, I should say. And so it comes into the bile ducts. They come down, it comes into this main one, and then if there's no stimulus for the bile to be released, then it will go back up into the gallbladder where it's stored and concentrated. And so there are several areas that are important to keep in mind. Number one, or several functions I guess you should be aware of. One is that the gallbladder is very thin-walled and it's distensible, so it can offset pressure changes that come up from the opening of the bile duct. Secondly, the way the bile is set up, you have basically three main components. You have what are called bile acids, the breakdown products I was telling you about earlier. Then you have you have what are called phospholipids, and then you have cholesterol. And so the bile is kind of like sugar in iced tea. It doesn't take much for it to fall out of solution, and so there's a very delicate, a very careful balance between those three things. And so if there is an imbalance, then the cholesterol can come out of solution, much like sugar will come out of solution in iced tea and form at the bottom of your glass. And so that's one important thing to know. The second thing that's important to know is that when the food comes into the stomach, it's held there until the food is processed and the particle size is less than 3 millimeters and the concentration is like the bloodstream. Then it's allowed through the pylorus into this area, this C-shaped area. And so about 70% of what you eat will leave your stomach within about 2 hours. About 50% will leave within 90 minutes, and nearly all of it's gone within 4 hours. And so that's kind of helpful, because that that timing lets us, kind of gives us a hint when a person has symptoms. Because again, if you have symptoms that after eating that occur, within 10 minutes or immediately or 10 minutes, obviously the food, unless you've had abdominal surgery or stomach surgery, the food's still up in the stomach. It hasn't even gone through here to lead to stimuli that cause the pancreas and the gallbladder and the bile duct to work. And so when food gets into this C-shaped area, a chemical called CCK, cholecystokinin, is released. Another one called secretin. But CCK is released, it goes out, floats around, and it stimulates the bile flow. It also makes the gallbladder squeeze and the opening of the bile duct release, so that bile comes in to mix with the food. And bile is really important in terms of fat digestion. Then that same CCK will stimulate the pancreas that's running back here behind the stomach to release its digestive juice, which is inactive. And so once that gets down into the bile, or into the small bowel here, then the bile will activate it, and then you have your digestion starts up, and things really get going. The pressure in the bile duct is a little bit less than the pressure in the pancreatic duct, and so that it's almost like epoxy. You have these two substances that are really not active alone. Once they mix together, then things start happening. And so the pressure favors the pancreatic juice coming out first, and then the bile will follow, and that'll be important here in just a few minutes. So when you look at areas where there can be problems, you can obviously have problems with gallstones. You can have problems with the gallbladder being lazy. You can have problems with the opening of the bile duct down here, and you can have problems, of course, in the pancreas, which we'll talk about in a few minutes. And so when you look at symptoms that we think might be related to the gallbladder or the pancreas, they are symptoms that come from food related, that come after eating food. So usually an hour or two after eating, we do know that about 15% of the input to the stomach, your biliary tree, the pancreas, comes from the brain. And so when you start thinking about food, when you start chewing those things, we know that you do get some degree of acid production from that alone without even eating anything. We also know that the pancreas juice, some component of its stimulation, maybe 15%, it comes from thinking about food, and the same thing with the function of your biliary tree. So like all things in medicine, it's not a perfect, the symptom presentation doesn't cover everybody uniformly, but that's generally how we think about it. And so what are some symptoms that can be caused by gallbladder problems or pancreas problems? Well, just from the location, you can tell that these organs are, your right rib cage runs this way, your left rib cage runs that way. So these are symptoms that are usually going to be above the belly button. And so you have abdominal pain, which in the case of the pancreas is when you really get pancreas pain, meaning like what's called pancreatitis, which is inflammation of the pancreas. It is bad pain. It's adult pain. It goes from the mid-abdomen, usually radiates to the back, because the pancreas is what we call retroperitoneal, meaning that it's plastered up against the inside of your back. And so usually severe pain, unrelenting, it can last up to days at a time, and usually you're going to be hospitalized. It's a very, very difficult pain to deal with. With your gallbladder, usually pain that comes about an hour or two after eating. It's a pain that builds up, it kind of stays there, and then it'll ease off, what we call colic. And again, usually lasts for not just like fleeting, just a few minutes. It usually is some pain that is one that goes over a course of hours. With the gallbladder, because your diaphragm is here, you can sometimes have pain. This because of the way the nervous system works. You have what's called referred pain. So you can actually have chest pain. I've seen that. You can have pain that goes to the right shoulder, between the shoulder blades. And so these are a kind of referral patterns that you can see. So some people don't have a whole lot of pain right in the middle, in the classic right upper quadrant area. Certainly nausea and vomiting is part of that, both for the pancreas and for the gallbladder. If a stone, if there is something that happens, a stone gets out into the main drainage system here, it can block the pancreas drainage system, and that can lead to pancreatitis. Or you can even get a buildup of bile in the body, and so that's leads to what's called jaundice when the bilirubin gets over about 3. And so you can have yellowing of the eyes, yellowing of the skin. The area that you actually see yellowing first is what's called where the structure called the frenulum, which is a little tissue that's underneath the tongue and attaches your tongue to the bottom of your mouth. That's the first area we see it. Yellowing of the eyes. You can also have tea-colored urine, because when the bile cannot get into the intestinal tract, it will then spill over into the urine, and so that gives you dark urine. The stools can become light in color as well, because you don't have the bile pigments which color your bowel movement. And so these are the symptoms that we look at. When you look at the blood work for these disorders, usually diseases of the gallbladder do not give you any blood work abnormalities directly, unless you're talking about just an elevated white count, like if you have an infection, or if a stone or debris gets down to the bile duct to block it, then you can have abnormalities in your liver function test. The tests for the pancreas, the blood test, are basically amylase and lipase. And so if those are 3 times the normal limit, and you have abdominal pain, that's almost always going to be pancreatitis. That's basically diagnostic. Obviously, X-rays are involved in your evaluation. Regular X-rays are not very helpful, but obviously ultrasound is used commonly to diagnose liver disorders and also gallbladder disorders. And ultrasound is very good. It's not perfect, and so you have body habitus limitations. The bigger you get, the more difficult it is to do a good exam. But it's right about 95% of the time, but it's wrong about 5% of the time when it comes to gallstones. Also, ultrasound is not so good for looking at the pancreas. It can see the head of the pancreas, but not the rest of it, because it gets behind intestinal air or stomach air. Another commonly used test is what's called a CCK hydroscan, and CCK is the substance I told you about that's released from the small bowel wall, and it goes out into the bloodstream and makes your gallbladder squeeze and the bile duct open and the pancreas juice flow. With CCK, we can measure how well the gallbladder is working. And so the gallbladder, when you get this initial injection, you then get a second injection, which makes the gallbladder squeeze. That's the CCK. And normally you should get rid of at least 35% of what's in there. If it does not do that, or it reproduces your symptoms, then that's a good sign that the gallbladder is the problem. You can also do MRI of this area, what's called MRCP, which is magnetic retrograde cholangiopancreatography. And so in that set, and what we're doing there is we're actually using contrast and differences in the magnetism of these areas to look at to get images of the biliary tree and also the pancreas. So usually in that setting, we're looking at whether there's a possibility that a stone or debris is out in the main bile duct. The other way, the more traditional way of doing that is with what's called ERCP, which is endoscopic retrograde cholangiopancreatography. And so what that allows us to do is to go down with a scope and manually go up into the bile duct and the pancreas to both make diagnosis and also to treat problems there. The problem with it is that it does carry a risk of irritating the pancreas, which you don't have with the MRI. And so usually, unless you have predictors, highly accurate predictors that there's a problem and that you're going to have to do therapy, you'll go with the less invasive approach, which is MRI. And so those are the main things that are used. Obviously, there's some other more specific tools, endoscopic ultrasound, that can be brought to bear, but those are the common tools that are used. So let's talk a little bit about the different disorders. The first one is gallstones, and gallstones are really common. Probably about 20 to 30% of Americans are going to get gallstones in this country. And in the old days, once you developed gallstones and we found them, gallbladder would come out. then that was found to be unnecessary, and so then it was just people with diabetes. And so it was thought that at the time that if you had gallstones and diabetes that you had a higher risk of complications, and as a result you get your gallbladder taken out. Then studies showed that we didn't need to do that either. So the way we practice now is if you have gallstones and you're not having symptoms, then we don't worry about it. We just you just don't do anything about it essentially. If you have gallstones and symptoms, then we like to see the gallbladder removed. And that's because we know that whereas your lifetime risk of getting a major problem with your gallbladder is about 20 to 30% lifetime, if you have a problem with it, then that goes up. If you're having symptoms, then that problem, the chance of a major problem goes up quite a bit. And so maybe as high as about 1% per year, which seems still a little bit low to me, but that's what's been in the literature for a while now. And so once you get symptoms, it's recommended that you get the gallbladder removed. Now, so that's gallstones. And gallstones give you symptoms because when your gallbladder is squeezing, one of those can be jammed up against a little tube called the cystic duct, which you don't see it real well on here, but it connects the gallbladder to the main drainage system. And so when that's occurring, then you're getting abdominal pain. When that stone falls back out, then that goes away. And so that's one way you get problems. The other way is that you get a lazy gallbladder, and that's kind of a similar thing. So with the ultrasound, you don't see any stones, and that leads to one other thing I want to say about it. That sometimes you'll hear about what's called gallbladder sludge, and gallbladder sludge is just it's like sand almost. It's cholesterol sand. It's coming out of solution, but it's mixed up with mucus. But it's not in the form of a stone, but you can still see it by ultrasound. And about 10% of people with sludge will go on to get gallstones. But it's real commonly seen in pregnant women. Probably 60% of pregnant women have sludge, and then once they deliver and the hormone status returns to the non-gravid state, then you end up with that going away. But some people will go on to get gallstones. But anyway, so as I said earlier, if the ultrasound is normal, then we will usually go to the CCK HIDA scan. And the way that's done is you get one injection, which the liver pulls out of the substance out of the bloodstream. It goes into the bile ducts, gallbladder, and then you get a second injection, which makes the gallbladder squeeze. It should get rid of at least a third of what's in there. And so usually with that situation, what you have is you have crystals of cholesterol which are depositing in the wall of the gallbladder, and over time it just basically makes the gallbladder lazy. The muscle function is compromised, and it just when it fills with bile, it just kind of sits there and does not squeeze back down. So both of the solution for both of those is the same. It's gallbladder removal. And when they do that, they leave behind the biliary tree. The gallbladder is removed. This is done laparoscopically. So you have a few small incisions along the rib cage, which runs here, one at your belly button down here. And the vast majority of the time, you're going home that same day. And so again, what happens afterwards is that the bile is more or less flowing into the bile duct, and it just continues to flow in, whether you have food here or you don't. And so the vast majority of people don't notice any problems at all when their gallbladder is removed. But there are a couple things that can happen. One is that the bile can reflux back into or go back into the stomach. That's what we call bile reflux. And that can give you various symptoms from abdominal pain, nausea, vomiting. You might even have reflux of this bitter liquid. And it doesn't respond to antacids because it's not an acid problem. It's more of a base type problem. So that's something that we'll use. We'll use medications like what's called cholestyramine, Cholestid. These are medicines that bind bile. Sometimes Carafate, which is known as sucralfate, which coats your stomach. It's an old ulcer type medication, and so we'll deal with that. Then the second thing that can happen is that when the gallbladder is removed, you can still form stones in the bile duct, especially as you get older. And so maybe up to 15% of people will do that. And I think that number is a little high, but that's what I've read over the years. And again, in that situation, sometimes they'll pass on their own, but that's where we usually have to go down with a scope and go back up into the bile duct to deal with that. The third thing that can happen is that bile, when it leaves this area, goes down through the small bowel and is reabsorbed in this last section of the small bowel. You may not be able to see that the way I focused this picture, but anyway, and that bile is recirculated back to your liver, back to the bowel, several times a day. And so what can happen is that some people can waste bile, and then it pulls water with it, and that leads to a diarrhea. Again, it's very easily treated with some basic medications. And so that's the main thing that you see with the gallbladder, is you see gallstones, and again, a really common problem. Gallbladder cancer is not a very common cancer. It is seen in the setting of gallstones. And there's a condition called porcelain gallbladder, where you get calcium deposits throughout the gallbladder, and that was said to be, when you found that, you should get the gallbladder removed. I saw a study earlier this year which suggested that's old. The old data are not correct in that regard. But I think, again, if I saw that, I'd still have that gallbladder removed. Another thing that you'll run across in regards to the gallbladder are what are called gallbladder polyps. So, you have an abdominal pain or your liver tests are high, you get an ultrasound done, and they find what are called gallbladder polyps. And gallbladder polyps are just kind of like the same thing as gallbladder colon polyps. And so you can't, with this area, we can't sample it. So with a colon polyp, I can go in and remove the colon polyp, send it to the lab. Pathologist looks at it and says it was this or that, and you make your plans accordingly. But with the gallbladder, we really can't do that. We can't sample it. We can't do other things other than remove it. So there are two schools of philosophy with this. One is that you simply watch the gallbladder with ultrasound, watch the polyps. If they get bigger, get it removed then. The other is to go ahead and remove it when you find the gallbladder polyps. And since most people who get ultrasound do have some symptom in this area, I feel like that's the better way to go, because I don't want to wait until something gets bigger where we might actually have some cancer in a growth. And so I like to see that taken care of at that time. As I mentioned earlier, the bile duct problems are usually unmasked once the gallbladder is removed, and this is again because you no longer have the gallbladder offsetting pressure changes that come off of the malfunctioning sphincter down here at the opening of the bile duct. And so I'm not going to get into that too much. That's highly specialized. Now, moving into the pancreas. The pancreas, obviously all the organs are important. Your pancreas function is to make a digestive juice that breaks down your food. It also makes insulin, as I said earlier. And so unfortunately, probably one of the more common things, and I haven't said a whole lot about cancer in any of my videos because that's we diagnose it, but other people treat it. But pancreas cancer is probably one of the more common things that we see, and it's the 5th leading cause of cancer death in this country. And it's a devastating cancer. I mean, just about everybody dies from it. And the 5-year survival rate is about 5%. And so it's obviously something that if you can find it, you want to find it early. Pancreas cancer is often most of the time is unresectable when we find it, because it gets out of the area very early. So a centimeter tumor, which is like 1/3 of an inch essentially, about 30% of the time it will have already spread out into lymph nodes in the area, as compared to breast cancer, where a centimeter tumor has about a 5% chance of being in lymph nodes. And the other thing is that you have a lot of important structures running right through this area right here. And most of these tumors are in the head of the pancreas, which is right up against where the bile duct comes in, and also a bunch of vessels that run through this area. And so there's one in particular called the superior mesenteric vein, which runs through here. And if it's more than 50% of the 50% of the circumference of that vein, then it's not resectable. And so your chemotherapy is better than it used to be, but it still only gives you months. And so your best chance of cure is with surgery. Probably about 25% of the patients when we first find it are surgical candidates. When the surgeon gets in there, only about 25% of the time will they actually be able to remove it. And like I said, a lot of the time you've already got lymph node involvement, and it's a matter of months. Plus, it's a huge surgery. You've got to basically reroute a bunch of different structures that are in here. It's the biggest abdominal surgery, and it's very hard to get over that. A lot of times people are elderly when they develop this, and all those things, along with various medical conditions like heart disease, make for a high chance of not surviving the surgery and the post-operative period. So it's really a big problem. So the second thing I want to tell you, so that kind of deals with cancer. It's obviously a much more sophisticated subject than that, but that gives you an overview. The second thing I want to talk about is what's called pancreatitis. Now, pancreatitis is a situation in which your pancreas gets irritated, and the two most common reasons for that are alcohol and gallbladder type problems. And the reason the gallbladder is involved in this is because debris can come into the main drainage system and then get down here and block this opening, and we think that leads to bile being forced up into the pancreas. The pancreatic juice gets activated and it basically digests itself. And so that leads to obviously pain and abnormal lab tests and CAT scan findings and this kind of thing. And so the basic liver test will help us tell if there's a possibility of a stone being involved in this. And then, of course, radiography can show that the bile duct is bigger than it should be. And in that situation, we're going to, if it doesn't pass on its own, then we're going to go down with the scope to retrieve the stone, get it out of there, and open up the bile duct. So that's one thing that can lead to pancreatitis. And I told you about the symptoms earlier. And then the other major offender, of course, is alcohol. And alcohol is a direct poison to the pancreas, and it's one of the things, that, again, we all know people who drank forever and nothing happened, but it is one of the things that is a major cause of that. Other things can cause pancreatitis. We feel that we're starting to think that smoking is as important risk factor as is alcohol. So that's one of the things I look for. You can have high calcium levels can do this. High triglyceride levels can do this. So these are things that we check on your basic labs. And then, of course, medications. There are a number of different medications that can do it. I don't want to get into all that. But again, the symptoms for pancreatitis: upper abdominal pain. Usually, you're not going to be able to tolerate that at home. Usually you're going to require intravenous narcotics and fluid support. And then usually what happens when you're admitted is that you're then put on a liquid diet, and then that's kind of advanced to a low-fat diet. And some people argue whether you need to do all that, and that it should not be a particular period of time between your moves on the diet. But again, that's usually determined by the person taking care of you in the hospital. Another thing that we can see is what's called autoimmune pancreatitis, which is where your immune system attacks the pancreas. And it's not a real common problem, but it is something that there are definitely people who have it. There's a particular blood test that we use. There's also a particular appearance on CAT scan that tells us if you have it or you don't. And so, and again, we usually don't do pancreas biopsies unless we're doing biopsying a tumor, because it can lead to pancreatitis, and also it can create a connection down the track that you have made in addressing this. One instrument that we do use is called endoscopic ultrasound, and it's where we have an ultrasound on the tip of an endoscope that allows us to look through the wall, and so it allows us to drain things, sample things, and take care of issues. Another thing that you may hear about is what's called a pancreatic pseudocyst, and this occurs in about 10% of people who have pancreatitis, and it's basically where the pancreas has digested itself, and then it leaves behind like fluid-filled bubble. And so unless it gets to a big size, it usually doesn't cause any problems, but it can push on the bile duct, it can push on the stomach, occupying a lot of that, and so some people can feel like they're filling up easier than normal. Those can be drained by burrowing, basically creating a connection through the stomach wall with an endoscope. It can also be drained externally by radiologists. Sometimes they require surgery, but the vast majority of them will go away with time. You can also develop cysts in the liver. When I talked about in the pancreas, so when I talked about the liver, you can see cysts there, you can see them on the kidneys and elsewhere, but you can also see those in the pancreas. These we watch because sometimes they can be precursors for pancreatic cancer. So usually we don't mess with them unless they get to about a 3 centimeter size, or if there's a solid component on imaging, in which situation you're going to definitely do some sampling and look for markers and things like that. The final thing I want to talk about regarding this is kind of the end stage process of irritation of the pancreas. So let's say a person gets recurring episodes of pancreatitis, and you can even have a familial form of that where it's inherited. in which you don't inactive, where a digestive enzyme does not get inactivated and can actually digest the pancreas itself. So the end stage result of that is what we call chronic pancreatitis, and this is usually something that we don't diagnose until late in the process. So usually it'll show itself because a person will develop diabetes, or they might develop diarrhea because they're not making digestive juice, or they're having chronic abdominal pain. And so we can look on the CAT scan and we can see that the drainage system is not smooth anymore, that you have these dilations and areas that are constricted, like what we call chain of lakes, and then you have the drainage system kind of dilated, and the gland looks atrophic, meaning it doesn't look like it just doesn't look healthy. And so that can be the end result, and so it can lead to diabetes as one consequence. Sometimes you need to be put on digestive enzymes to make up for the fact that your pancreas is not making the digestive juice anymore. It can also lead to chronic upper abdominal pain, which can really be quite bad. And we're not sure exactly why that happens, but it seems to be related to chronic inflammation around nerves that come through this area. And you've got a big nerve trunk behind the pancreas called the celiac plexus. And so that seems to mediate pain not only in chronic pancreatitis, but also with pancreas cancer. And so with chronic pancreatitis, pain control can be difficult because then you're looking at narcotics, and then we also give you a digestive juice, which works okay. And attempts to block the nerves that go to the pancreas have not been very successful, in my opinion, when it comes to just regular pancreatitis. Better when you're dealing with malignancy, but you have some side effects, like it can make you pass out because you don't control your blood pressure the same way. And but it's just like everything else I've talked about. You want to prevent that. You don't want to be the one that continues to drink and to constantly irritate your pancreas. You don't want to be that person that keeps smoking and has ongoing irritation of your pancreas and burning it out. So again, this is just one of those another thing that you don't want to deal with. So I hope that was helpful in terms of you getting an overview of gallbladder disease, biliary tree disease, and pancreatic disease. A lot of this area of gastroenterology is one in which we work very closely with our radiology and surgical colleagues, and there's really no effective medical therapy for gallstones. Since synthetic bile salts have been tried, they dissolve maybe 30% of the gallstones, really just the cholesterol ones, and not ones that come from other sources. And you come off the medication, your gallstones come back. What's called shockwave lithotripsy, which is used in kidney stones, is no longer available in the United States. It is available in Europe, but a lot of problems develop because the stone fragments would not pass, and sometimes they cause pancreatitis. So not as good a procedure as you see with the urologist. And really these things that people use in terms of alternative medications are just not helpful. I want to say one thing about what I know that some people use, and that's what's called a liver cleanse. And the thing you have to understand about the way our body is designed is that if you could easily change your pH, if you could easily clean your liver, we'd all be dead, because you could so easily perturb the physiology of these organ systems in your body overall that there's no way you would survive. And so, again, liver cleanse, I think it's an oxymoron. You just don't cleanse the liver. Liver does fine cleaning itself. The main thing you need to do with your liver is don't insult it. The main thing you need to do with all these organs, your pancreas, don't insult it. Control what you put in your mouth and what you suck into your lungs, and certainly don't inject things into your veins. And that's the best thing you can do. But as far as being able to clean your liver, or do something that affects your biliary tree, it's just not possible right now. And if it was, we'd be in big trouble. So I hope that this has been helpful. Again, if you like to come visit with me, love to see you as a patient, and I hope otherwise that this will help you ask better questions of your providers and better use your healthcare dollars. Hi, I'm Sean Panzer, and I'd just like to take a few minutes just to let you know about some of the different things that we offer through my office. Obviously, I'm a traditionally trained gastroenterologist from Baylor College of Medicine in Houston and Johns Hopkins up in Baltimore. But obviously things change over time, and so I think it's important that a person also get kind of keep up with the times and be contemporary. And you also want to balance that with things that you know have worked from the past, because a lot of times things come up that are that seem to be awesome and something you want to put in your practice right away. But a lot of times you need the kind of the percolation of time to make sure that the procedure is truly safe and is one that's going to benefit a patient. And that does take a combination of experience and knowledge of the literature and other things. So I just want to make you aware of some other things that we do. Of course, you can obviously see me in the office, kind of the traditional way, but I also have telemedicine, which allows a person to have an office visit, a follow-up office visit over Google Duo or the iPhone FaceTime. And I can't do new patient visits that way, but it is covered by insurance and Medicare. And I use that a lot in people who have to drive or can't get here easily, or off in other places like in school, that kind of thing. We also have a nurse practitioner named Toni Perkins. She's sees patients while I'm here in the office, and her practice is mostly focused on helping people who need to be worked in that cannot be worked into my schedule, and so she's also available. We also do in-office hemorrhoid banding with a system called the CRH O'Regan system, and this is kind of the latest version of hemorrhoid banding. I've done hemorrhoid banding since I read about it, the endoscopic version in 1996, but this newest version is basically a painless version that does not require colon preparation. I can do it right here in my office, again covered by by Medicare and also by private insurance. We also have a type of radiology device that's called FibroScan. This allows us to quantitate, not only it uses an ultrasound technology which allows us to quantitate how much fat is in the liver, and it also allows us to tell liver stiffness, which correlates to how much scar tissue is in the liver. So if you have a chronic liver problem, such as hepatitis C or fatty liver, then we can use this to, in a non-invasive way, to give us an idea of how much scar tissue you have. This may lead to a change in your management, either through medical management or to referral to a tertiary level medical center slash liver institute for more for access to possibly clinical trials and other things. But in the past, the only way we could do that was with liver biopsy. You can also get similar information from an MRI, but MRIs are very expensive and it's very difficult to do a good MRI. The last thing I want to talk about is an alternative medication line that we're developing for digestive diseases. And the alternative medications are it's a big industry. There are a lot of people that carry the medications, drug stores, grocery stores, and all that. And there are just so many different products and so many different things out there, and it's just kind of mind-boggling, really. The unfortunate thing with a lot of those, for the vast majority of these supplements and minerals and herbs and these things, is that there's just no clinical data. So a doctor like me who prescribes your standard prescription medications, all of those had to go through scientific studies in which they were compared to placebo. They went through animal trials. They went through patient trials. And then a lot of times we have years of experience with these. And so we know that they work better than a placebo. But a lot of people are turned off by big pharma and the expense and just the suspicion that the medicines are not good for them, side effects, this kind of thing. When you turn to alternative medications, you have even a worse problem because you have so many different chemicals that are put into one product. You don't know which one works. You don't know which one may be interacting with medicines you're already on, that kind of thing. But people seek that care a lot and go to non-traditionally trained individuals and put a lot of trust into people that have not spent a lot of time either practicing medicine or studying medicine. And so what I'm trying to do over the last year is educate myself more about the things that are out there, try to get as much information as I can, scientific information, to help me make decisions as to what may work and what may not, and what does not work. And so that's what I've been trying to do is we're putting together a product line that will allow us to treat the things that we see. And so we're going to use these as a combination with the traditional medications, and hopefully we'll get better results as a result of that. These medicines will be available in the office. They're also going to be available online on eBay store as well. And so please give them a look. And obviously when you come to the office, I'll definitely describe those. But again, the idea is to get some kind of a product line that I can feel good about in terms of the production and also standardization, and where we can combine it in a controlled way as compared to just going out and taking a handful of different supplements that may be countering each other or just not doing anything for you and wasting your money. The last thing I'd like to talk to you about is hydrogen breath testing. This is technology which allows us to measure how much hydrogen you're exhaling, and our bodies don't make hydrogen, only bacteria do. And so what this allows us to do is to look at, to see whether or not you are possibly malabsorbing different things, such as lactose and lactose intolerance, fructose intolerance, and also what's called SIBO, which is known as small intestinal bacterial overgrowth. This is a condition in which you have bacteria in your small bowel which should not be there, and in too high quantities, and as a result they are interfering with the function of the bile and also the digestive juice made by the pancreas and by your small bowel lining. When that happens, then you don't absorb things the way digest and absorb things the way you're supposed to. They go lower in the bowel where they're broken down by bacteria, and that's fermentation, and that can lead to anything from gas and bloating all the way to diarrhea and even weight loss. So it's something that's part of our workup of symptoms like gas, diarrhea, and bloating. So we're, like I said, we have these available now. We're always looking to add things that I think are going to be helpful. These things are covered by insurance, and with the exception of the supplements. And I hope you give these things a look. Thanks for your time.